I'm going to start with the People's NHS as we finish with the table there, commissioning for the people, and that is important. We talked therefore about involving the patients and the public in commissioning decisions, but getting over the fear that if we ask the public about what they're looking for, we might get the wrong answer or we may not be able to deliver. So deliberative approaches came out as a way of trying to bridge that issue and get over some of those risks. We talked about commissioning having evolved over 20 years, and we heard from Conor and Ken and also from Judith that the focus has shifted more to quality and outcomes, but successive restructurings perhaps have been a little disruptive, and we have still some way to go for commissioners to be able to identify problems in providers and then to help remedy them when things go wrong. When they do go wrong, what we heard today was clinicians in the new commissioning groups, one of the key things they need to do is to be very dogged about making sure that they follow through with their providers, but also perhaps asking for the right networks and support from other clinicians in the right specialties to be able to bring support and scrutiny to what's being done locally. We heard this morning that perhaps we've had too much focus around the current changes around structure, and perhaps more discussion needs to be held around the physiology of the new arrangements and how they're going to work. And we've certainly heard quite a lot of discussion this afternoon about how they might be different. Some of the things you mentioned were around the use of better information. We heard some examples this afternoon about masses of different sources of information that are available to clinicians. They need also to be picking up the soft intelligence that they get from their patients and discussions with clinical colleagues in the system. That's just as important as the hard evidence. Other things that might make a difference, contract currencies, whether it's pathways, years of care, individualised packages of care, or quality incentives that we heard about this afternoon. And as well as the public and patient engagement, you talked about GPs getting out more, getting into hospitals, perhaps seeing their patients in those environments and pulling them out, but also taking that as an opportunity to really understand what's going on in their local providers. This afternoon we also heard that commissioning is a team effort. We've got clinicians bringing their clinical expertise, some of their management expertise, but they need to be supported by good managers and by public health specialists and working with local authority colleagues. That's part of the team. The public and patients are the other crucial ingredients. We've talked a little bit also about the levers for change, whether it's a duty of candour. The debate perhaps it still needs to be had. There may be other ways in which that culture shift can be made to happen within providers. And I think that we heard that from Conor and Ken too, that you can have the right governance arrangements, the right assurance framework in place between commissioners and providers, but if your providers doesn't get what it's about and its main focus is on quality, then that's a really tricky situation to be in. So getting the providers focusing on the right things and getting that culture around putting patients at the centre continues to be something that's very important to the system going forward. So there's just a few things that I pulled out. No doubt there'll be other things that you will take away, and we thank you very much for your contributions today. I'm going to hand over to Robert now just to say a few words to close.
Thank you very much to Sarah, who I can now at the end of this long series of seminars, and it must have seemed very long to her, has performed admirably and demonstrated the skills that actually mean that she should have been chairman of the inquiry, not me. And certainly she should have written the report, if she hasn't done so already. Her ability to summarise things is spectacular. I'd also like once again to thank our speakers today, who have been diligent, brave and very helpful. And I'd like to thank you for your contribution. If I can end with just a couple of thoughts that occurred to me listening to today, and perhaps linking them up with some of the other seminars. In the course of the evidence of the inquiry and today and in other seminars, I've heard a lot about, as it were, the power balance within the NHS. And today it's been about the perception, at least, that perhaps power resides with the provider trusts because it's too difficult to press nuclear buttons, to leave communities without care, and so on. And the question I think I might have to look at is whether that is, to some extent, an omission to look for appropriate levers, but secondly, perhaps part of the putting things into the it's all too difficult box, and to use it as an excuse for inaction, and to adopt a very striking phrase used today, to produce a collusion of mediocrity. If new commissioning arrangements are to mean anything at all, I would hope they mean that if there is a power imbalance, it is redressed. That brings me to the second point, which is come through, I think, very powerfully today, but also in other seminars, which is about the power of information. Information nationally and locally. One of the reasons I asked a question for you to look at about candour is that information is only as good as the accuracy with which it is given, and the honesty and transparency that are associated with it. I was actually asked by Steve what did I mean by the question, and I told him an anecdote, and I will share it with you to understand where I come from. It's an experience I had outside the inquiry, but as a result of the first inquiry, I was asked to go and see various people, and including worried boards who wanted to know whether there's anything I could do to help them. Usually the answer was no. But I had a very pleasant dinner with a board of a foundation trust who wanted my assistance with regard to the transparency of board engagement, and public board meetings was the sort of topic. But in the course of the general conversation, which I was then listening to, enjoying my glass of wine, a problem was being discussed internal to the trust. And someone mentioned whether or not the PCT knew about this problem, to which the answer was no. And I innocently asked my neighbour, well, shouldn't they be told about it? And the answer was, not until we've completed our negotiations. Now, that person I was talking to was a non-executive director from a business background where it would be second nature to keep commercially confidential information to themselves because it would prejudice a negotiation. One would rather hope that that isn't how commissioning and commissioners' relationship with providers will work in future, even if it does now. But another board told me, couldn't understand my recommendation, that board meetings should be in public. I was asked by a director from a very large financial institution, well, we don't do that in our board. We don't let our shareholders come to board meetings. So one has a cultural issue about transparency that has to be defeated, I think, if information is to be truly available and truly used. But the other thing about information is it must be, we talked about this the other day, made public. We heard yesterday from the lady from John Lewis, and she said something I thought, well, it wasn't about information as such, but was very relevant. She was describing the interaction between frontline staff and customers when the customer makes a complaint, and what they train their frontline staff to do is two things. One is to understand that they probably feel afraid about the complaint being made, but they need to understand that the complainant is also afraid, and your job is to deconstruct that fear. Well, the fear of sharing information rather falls into that category, it seems to me. But the other thing about information, it's about acquiring it. And another thing she said struck me there, which was we have systems for dealing with complaints and customers being unhappy, but all staff are empowered to go not to use the system, but to exercise their judgment about how to deal with the problem if they feel the system won't solve it. So in other words, it's more important to solve the problem than to follow the system. And how, if you do that, of course, you should tell someone about it, and there should be a discussion about whether there was a better way of doing it, or maybe of amending the system. So within that package of information and openness and honesty, and not being overwhelmed by systems, it seems to me there's a lot of wisdom. A lot's been said today, as in other seminars, about public involvement, and I've heard discussion here, obviously, about the challenges involved in that. A figure of speech was used yesterday in a slide about tsunamis, and there is a tsunami of social media interaction and so on going on out there. But I used a phrase yesterday, and we'll use it again today. There is a tsunami of anger heading towards the NHS, which will overwhelm people paddling their canoes, carrying on as though nothing is happening out there. There is an absolute necessity of engaging in an uncomfortable way. It will feel uncomfortable with the public, but they are the people for whose benefit the NHS is run, and whose service, as we now know, it is, Table 5's service. And Anthony Samara's suggestion in one of the seminars, and it's one for considering, is that every trust, and I suppose therefore every NHS organisation, should have a Julie Bailey. What he said was, if there isn't one, invent one. And there is a need to have someone who, with authority, often moral authority, is able and willing to ask the really uncomfortable questions, and more importantly, carry on asking them until they get an answer. Happily or unhappily, I fear that part of my job is to ask those uncomfortable questions, and if necessary, provide uncomfortable answers, but that's one of the many things I will have to do. But anyway, thank you very much for coming today. I think this has been a very helpful seminar for me, and unlike most seminars, of course, this is for the benefit of the chairman, me, rather than you, the participants, but equally I hope you go away with some benefit yourself. Thank you.